Good afternoon. Good afternoon, and thank you all for joining us. This is quite an event as we have over 400 people that have registered today, which speaks volumes to the fact that, first of all, these webinars are working and people are getting the information they need, but also that there are more and more patients or people being diagnosed with an MPN. I think Mallory, who is with me today, I'm Ambrazo with MPN Advocacy and Education International. In case you don't know me, I've been around for 18 years now and in the MPN space. And we have been hosting these webinars since the pandemic and will continue to do so for the duration of not only the pandemic, but forever, because they have been so successful in reaching people that we normally would not reach. With me today is Dr. Kristen Pettit, who is an MPN specialist at the University of Michigan. She's been on our programs many, many times and highly respected in her field. And she's going to talk to you today about bone marrow biopsies, about phlebotomies, about transfusions, about the very basic things that happen very often when you're first diagnosed with an MPN, but also throughout your journey with an MPN. So without further ado, because we do only have 1 hour today, I'm going to turn this over to Dr. Pettit. Please welcome her.
Okay, great. Thanks so much, Anne, for having me. And it's good to see everybody virtually. Please let me know. I had some issues with my microphone earlier. So if you can't hear me, if I'm not loud enough, please let me know and I'll try to adjust it.
It's sounding great right now.
Okay, great. Thank you. Okay, great. So I understand we have a lot of questions, which is great. And that's really what I want to get to. But I at least have some slides here to go over some basics about MPN blood work, biopsies, things like therapeutic phlebotomies and transfusions, at least to get some of the language out of the way. So this is really speaking a whole new language when you're dealing with a new diagnosis of MPN. So I want to just kind of lay some groundwork and then I want to get to your questions. So as most people on the call probably know, but I'm going to start slow for anyone who's newly diagnosed or dealing with this situation for the first time. So MPNs, these MPNs are a group of related bone marrow disorders in which the bone marrow really overproduces blood cells, whether it be the white blood cells that usually help fight against infection, the red blood cells that help carry oxygen, and or the platelet cells that help the blood to clot when it needs to. It can all be overproduced in MPNs. In addition, the other thing that's overproduced are these substances, these proteins called pro-inflammatory cytokines that also are produced from bone marrow cells, overactive bone marrow cells, and contribute to a lot of aspects of the disease. So all this together, increased blood cell production and increased production of these pro-inflammatory cytokines can result in a number of things happening to an individual. The one thing that can happen is these things called constitutional symptoms. So when we say that word constitutional symptoms, we mean kind of non-specific symptoms that can impact somebody's quality of life and make them feel generally crummy. So fatigue or tiredness is the #1 thing that we see in all types of MPNs. Weight loss can happen, night sweats, fevers, chills, all of those things can happen, as well as a variety of other symptoms that I'm sorry to say that many of you have probably experienced, but have hopefully had some experience in managing. Other things that can happen as a result of both increased blood cell counts, kind of sludging up the bloodstream, as well as production of those inflammatory cytokines. Those two things together, increased blood cells and increased inflammation in the bloodstream, can contribute to thrombosis. By thrombosis, I mean blood clots. And blood clots come in a variety of different forms. They can happen in veins, which causes a deep vein thrombosis, for example, one leg that becomes big and swollen and uncomfortable, or PEs, pulmonary embolus, which are when these DVT blood clots can travel to the lungs and cause chest pain, shortness of breath, anything like that. When a blood clot happens in an artery, those are things that we think about like heart attacks or strokes. Those are also an increased risk. We can also see a progression over time in people who are initially diagnosed with polycythemia vera, PV, or essential thrombocytosis, ET, we can see a risk of progression over time to the condition called myelofibrosis, MF, where the blood counts, instead of being too high, tend to drop too low and scar tissue starts to build up in the bone marrow. With all three of these MPN conditions, we also see an increased risk of developing something like acute leukemia, AML, down the road at all. Though the risk is low, the risk is there, and that's something we're always watching for, and I'll show you how we're watching for that in your bone marrow and blood. So as I was putting together these couple of slides, I realized how much jargon we use in the MPN world. So all of these are common words or abbreviations that I use on a day-to-day basis and sometimes don't slow down to think about explaining. So I'm glad that we have the opportunity to explain really what all of these things mean in some way today. Okay, so let's start with blood tests. I thought it would be fun to have some visuals here. So one of the things that really drew me to hematology in general as an area to practice was how visual it is and how we can actually see the diseases we're treating with our eyes, and we can also see them either worsen or improve, hopefully improve over time visually with our eyes. So this is an example of a normal blood smear. So when you have your blood drawn in the lab, it of course goes in a little tube. They send it down to the laboratory. Down there, they make a very thin smear of it on a glass plate. And then on that thin smear, when they smear it out, so it's just really one cell layer thick, we can take a look at all the individual cells under the microscope. So this is how normal blood looks under the microscope. So these are all the red blood cells that are shown here. You can kind of take note of how they look, how they're spaced out. They have a little bit of a central area that's more pale because they're actually kind of a little bit like dumbbell shaped if you look at them from the side. Those are the red blood cells. These are the white blood cells that you're seeing in here. These in particular are neutrophils that we're looking at. We'll talk about the different types of white blood cells, but they're a little larger than the red blood cells. They've got this funny looking different lobes of the nucleus that's here in the middle. And then these little guys, this much smaller little cell fragments here are platelets. So you see one here, they're kind of spread throughout here. So kind of take note of how frequent or infrequent they are here in a normal blood smear. And then we can compare and contrast that to blood from somebody with ET here at the top. I'm sorry, this image didn't copy over super well, but you can see all of the platelet cells here. So all these little dots, the smallest cells there, those are platelets. So you can see in this smear here a good example of a pretty significantly increased platelet number in this blood sample. When we're looking at a sample from somebody with polycythemia vera, you can see most notably how many red blood cells are here. So as opposed to being kind of spaced apart and having some empty space on the blood smear and in the normal situation, in PV, the red blood cells are all over the place, kind of clumping on top of each other, and you can see they're really increased. And then lastly, in myelofibrosis. So with this example of a patient with myelofibrosis, you can see that the red blood cells are really spaced further apart. So there are fewer red blood cells. This patient was pretty significantly anemic. We see fewer white blood cells too, really just one little white blood cell there. And in this sample of the blood in this particular patient, we actually don't see any platelets here. Actually, maybe there's one down on the right over there, but really decreased numbers of cells overall, red blood cells, white blood cells, and platelets for this patient with myelofibrosis. So let's talk a little bit more about the CBC, the complete blood count, and what all these things mean. The reason that we do this over time frequently in patients with MPNs are, first of all, upfront for diagnosis. We'll talk about that a little more. Secondly, that the blood counts are important to look at for prognostic purposes as well, especially in myelofibrosis, to help us kind of predict how aggressive or non-aggressive the disorder might behave down the road. Third, over time, we're going to be repeating the blood counts, at set intervals, depending on your particular situation, to follow the response to any treatment and make sure we're meeting our treatment goals. And then fourth, in the complete blood count, we're looking for any signs of progression over time too. Any signs of movement of, for example, something like ET or PV into the realm of myelofibrosis or, heaven forbid, an acute leukemia. So let's look at the different parameters in the CBC next. I lost my mouse here. I'm trying to get it back. So looking at the different things that we see in the CBC, each CBC, depending on where you have your blood counts drawn, it'll look a little bit different as far as the layout. And I hope that all of you, I think an important point is that wherever you go to get your blood counts drawn, they should have hopefully an online portal that you can sign up for. We have one at University of Michigan. I think most labs or most health systems around the country have that. I think that's a really nice resource for you to be able to track your blood parameters, really to be able to look for this number 3 and number 4 up above for any signs of progression and to make sure that we're meeting our treatment goals. So of course your health team is looking at this, but I think it's important in being your own advocate or advocate for your friends or family members with these disorders to be able to be on that online portal and actually have access to the primary information too. So as you're looking at this, one thing that will be on there is a red blood cell count. That's just the pure number of red blood cells in 1 microliter actually of blood, one small little sample of blood. In situations of ET, PV, or myelofibrosis, these can be different than the normal ranges in each thing that we're looking at here. So red blood cell number, the normal range is shown here. In ET, it's usually about normal. PV, of course, we see increased numbers of red blood cells. And in myelofibrosis, it might be either normal or decreased. As far as the white blood cells go, normal ranges from about 3.5 or 3,500, depending on how your particular lab reads this out, up to 10.5 or 10,500. In ET, we tend to see the white count be slightly elevated or normal. In PV, similar, it could be elevated or normal. In myelofibrosis, it can be tricky because it can be either high, low, or normal. As far as the platelet count, normal range is 150 or 150,000 to 400 or 450,000. In ET, we see the platelets be elevated. In PV, they're often elevated, but maybe normal. And in myelofibrosis, they're more commonly either decreased or normal. Hemoglobin is listed here too. I'm going to do the next couple slides on what hemoglobin and hematocrit refers to. Hemoglobin range is slightly different. Hemoglobin and hematocrit ranges are slightly different between men and women. In ET, they tend to be normal. PV, they're elevated. And myelofibrosis, they tend to be decreased or maybe normal. So what do those red blood cell measurements mean? I'll start with the red blood cells. So by red blood cell measurements, we're looking at a number of different things. We're looking at the hemoglobin, hematocrit, red blood cell number, and mean cell volume, or MCV. So all of those numbers have to do with how we're measuring and assessing the red blood cells over time. So first thing that the lab will do is take a look at the actual tube of blood itself. So these are a few different samples here, a few different examples. When we're separating out the blood, when they send it down to the lab, they spin it out, they centrifuge it out. The heavy red blood cells fall to the bottom. That's the red range here. In the middle, there'll be something called a buffy coat. That's where the white blood cells and the platelets separate out to. And then the lighter elements, the water, proteins, hormones, nutrients, those kinds of things end up at the top of the tube in the plasma. So when we're dealing with somebody who has anemia, we generally see a decreased red blood cell content. And that's what the hematocrit really refers to, is the percentage of this total tube that is made up by the red blood cells component. So normal hematocrit ranges are listed down here. In anemia, we see that be decreased. And then in polycythemia, for example, in PV, we see an elevated hematocrit, or an increased percentage of the tube that will have the red blood cells in it. Another way that we measure the red blood cells is by the hemoglobin. So hematocrit is really the percentage of the tube, a percentage of the blood that is made up by the red blood cells. The hemoglobin is a very similar measurement, but just slightly different. So hemoglobin is the molecule inside red blood cells that actually carries the oxygen. So oxygen comes into the bloodstream from the lungs, it gets into the red blood cells and attaches itself to hemoglobin. Hemoglobin carries the oxygen throughout your bloodstream. And then when it arrives somewhere anywhere in your body, any tissues, organs, anywhere else that needs oxygen in your body, then the hemoglobin releases the oxygen and the oxygen is able to do its thing. So measurement of the hemoglobin occurs in the lab. They actually break up the red blood cells and then measure how much hemoglobin is there total. So hemoglobin and hematocrit tend to be very similar. They definitely track with each other. Hematocrit is usually about 3 times the hemoglobin, but not exactly. The hematocrit can vary just slightly based on, for example, hydration status. So if somebody is very dehydrated, you can imagine that their plasma component of their blood tube would be slightly lower. They'd have slightly less water there. So the hematocrit could look artificially slightly high. That really only happens in cases of pretty severe dehydration, but it's important to note that that's kind of the slight difference that can occur between the hematocrit and the hemoglobin. Otherwise, we kind of measure both of those numbers as sort of interchangeable. The mean cell volume, or MCV, is something I get questions about a lot. That has to do with the actual size of the red blood cell, the average size of the red blood cell, how much volume can be carried in there. MCV tends to be lower in cases of iron deficiency and tends to be higher in certain other conditions. So for example, when patients are taking hydroxyurea, hydrea, one of the ways that hydrea actually works is that it increases that MCV. It causes the red blood cells to be a little bit larger. Another reason the MCV can be increased or high can be if the bone marrow is very active and making a lot of red blood cells. The youngest red blood cells that come out of the bone marrow into the bloodstream are called reticulocytes. And those tend to be a little bit larger. And then as the red blood cell kind of goes throughout its life cycle, it gets a little bit smaller. So if we do have a situation where the bone marrow is very active, trying to make a lot of red blood cells, and we see a lot of those young reticulocytes, then that MCV number can be elevated as it's reflecting a lot of those larger, younger cells in the blood. So moving on to the white blood cell numbers. So the differential is how these are reported out in the blood test. There's a couple different ways that the differential is reported out. It's usually reported as both a percentage and then an absolute number down below it. So what this is referring to, this is a patient that gave me permission to show their differential unidentified today. So this person's white blood cell count was normal, 6.5, and their differential is shown down here. This is the percentage of white blood cells. So you can see of that 6.5 white blood cells, 52.4% of them are neutrophils. And what the absolute value is referring to is just that the system is nice enough to do the math for us. So 52.4% of 6.5 is 3.4. So the absolute neutrophil count, or ANC, is 3.4. And then on for the different types of white blood cells down here too. We see the percentage of the total and then the absolute number. We focus on both of these things for different situations, both the kind of the makeup or percentage, and then also the absolute numbers. So it really depends on a case-by-case basis, whether we're focusing more on the percentage or more on the absolute numbers, but usually we're looking a little bit at both. When we're looking at the individual white blood cells, just to go through them just very quickly, the neutrophil cells are the ones that really are the heavy workers, the heavy lifters of the white blood cell community. So the neutrophils are really the most active against bacterial infections, which are the main threat to our health on a day-to-day basis, because of course there's bacteria everywhere in your mouth, in your GI tract, on your skin, everywhere in our environment. So the neutrophils are really the soldiers that are keeping us safe from those bacteria, as well as some things like fungal elements or foreign debris that can be throughout the body. Monocyte cells are another one that we'll see listed on the differential. Monocytes are the white blood cells that they have some infection fighting potential too, but they tend to clean up damaged cells. So they're kind of scavengers of the bloodstream. Eosinophils, we'll see sometimes those will be 0% in the bloodstream, or they'll usually be relatively low. But these are responsible for cleaning up things like parasites, sometimes some viruses, as well as things like cancer cells that can occur throughout our bodies over the course of time, which is scary to think about. But the eosinophils are our friends that are keeping us safe from that, and also involved in allergic responses. So if you're having things like seasonal allergy issues like I am right now here in Michigan, your eosinophil count might be a little bit elevated in your bloodstream as those eosinophils are having an allergic response or forming an allergic response. The lymphocyte cells are really the viral infection fighting soldiers, and those are what are responsible for making your antibodies, your memory, your body's memory to prior viruses or other infections that you've been able to fight off in the past. And then basophils are the last one, which are also involved in allergic responses and in some forms of bacterial responses as well. So with MPNs, what we see being really the initiator of all of the problems in MPNs is a very early cell called a blood stem cell. So when we're talking about blood stem cells, we're not talking about embryonic stem cells. These are not the stem cells that can produce a whole human being or anything like that. But we have blood stem cells that live in our bone marrow that are able to produce all of the different blood cells for your body. The red blood cells, the platelets, the white blood cells, which consists of all those granulocytes that I just mentioned, as well as the lymphocyte cells. So this is kind of how their life cycle works. So we start off with a blood stem cell. It then divides itself into being either a myeloid stem cell or a lymphoid stem cell. And from there, further goes on to kind of grow up and differentiate over time into one of these other cells. One thing I'll point out here is this stage called myeloblasts here. We're going to come back to blast cells, but these can be some of the more problematic or troublemakers down the road that we're watching for closely in that differential. So some other important labs that your doctor will probably be checking to watch out for: BMP, or the basic metabolic panel. This tests your electrolytes and your kidney function, which is obviously very important. The CMP, or comprehensive metabolic panel, is everything that's included in the basic metabolic panel, the electrolytes and kidney function, plus it also includes tests of liver function as well. The LDH, or lactate dehydrogenase, is something that your doctor will probably be monitoring for MPN as well. LDH is not LDL, it's not cholesterol. I get that confused a lot though. I get to see that get confused a lot though. But the LDH is an enzyme that's in blood cells. So when your bone marrow is overactive or proliferative, the P in MPNs, when the bone marrow is proliferating, or when blood cells are being broken up in the bloodstream, which is called hemolysis, if either of those two things are happening, that LDH enzyme level in your bloodstream can go up. So we very commonly see the LDH be elevated in situations of MPNs. The LDH, that enzyme itself, is not damaging to the body. So there's no one level that's like a red flag or a concern necessarily. It's more about the trends. If we see the LDH be kind of stable for somebody for many years, and then all of a sudden see it take a quick upward trend, that might be a trigger for us to take a closer look and see what's changed and what's going on. So that's one tool that we have to monitor for disease changes over time. The uric acid is similar. Uric acid is also a substance that's in blood cells that can be increased in situations of proliferative or active bone marrow, as well as when blood cells are being broken up or hemolyzed. But if the uric acid is released too quickly, and if that number does go too high, as opposed to LDH, the uric acid itself can actually cause some problems. If the uric acid is really starting to build up in the bloodstream, it can stick together and crystallize. Those tiny little crystals can clog up the kidneys and cause kidney damage. They can also clog up in the joints and cause things like gout. And I have a picture of a foot here too. So you've probably heard about gout. Hope you haven't experienced gout. The most common place for this to happen is in the joint at the base of the big toe. Very painful, can be red and hot, and is caused by increased uric acid. So gout risk is something that we definitely watch for in people with MPNs, and there are various different medications we can use to bring the uric acid level down and then keep it down in the long term to help prevent kidney damage or gout. Okay, so Bone marrow biopsies. So popular topic that I get a lot of questions about. Really an essential portion of MPN diagnosis for sure, initially at diagnosis, but then also as far as determining prognosis over time and assessing risk of the disease progressing over time, the bone marrow can give us a lot of important information. We also use bone marrow biopsies serially over time to look at response to treatment in some situations and to look for progression if we're concerned that a disorder is progressing to either myelofibrosis or to an acute leukemia. We will want to do a bone marrow biopsy to look at whether or not that's the case. The blood, our blood tests do help determine a lot of these things, and the blood usually reflects what's going on in the bone marrow, but not necessarily perfectly. So we'll go over kind of what specifically we're looking at from a bone marrow biopsy and why we put you through it. It should be a relatively quick and painless procedure. There can be some pressure involved. We can't completely numb up the pressure aspect of it, but we really don't expect somebody to feel sharp pain as part of a bone marrow biopsy. So for those of you who have gone through this before, you obviously know these details. We usually have somebody lay on their stomach or on their side. The best place for us to get a sample of bone marrow is in what's called the posterior iliac crest. So that's the back of the hip bone, right as it kind of goes up and over here. That kind of, there's a thick portion of that hip bone that goes along the edge where that's a very good, rich source of bone marrow where we can get a really good look at what's going on and we can get a lot of cells from. It's also one of the safest places to do a biopsy in the body too, because there really aren't other, vital organs that we're going too close to right in that area. It's really just the hip bone itself. So that's why we choose that site as our spot for most bone marrow biopsies. We use a very thin needle. It's a lot thinner than it looks in this picture. It's a very thin needle that goes through the outer layer of skin here, and then through the bone and into the spongy bone marrow inside. We numb up, of course, all of these layers very well. The inside of the bone marrow does not have any pain nerve fibers, which is a good thing, but the bone marrow is kind of under a vacuum. So when we do pull out samples, you can feel that, that kind of pressure sensation when we pull out the samples. As far as what the bone marrow looks like when we take it out, this is what the kind of little solid section looks like. This is a larger section than we usually take, so I will say that. But we usually get about 1.5 centimeters to 2 centimeters of a very, very thin little section of bone marrow to look at with our eyes. Okay, and this is what we're looking for under the microscope. Oh, I'm sorry, the pager is always going off. This is what we look at. This is what this looks like under the microscope when we take that sample of bone marrow out. So on the left here is normal bone marrow appearance. So these white kind of clumpy things here, these are fat molecules, and that's normal to see. It's normal for the bone marrow to have some fat or empty space in there. And then in between that fat or empty space, you see all of these cells. Each little kind of dot here is a cell. Some of them are larger than others, but this is sort of what it looks like in a normal situation. Comparing and contrasting that to situations of MPNs. So when we look at ET or PV, this top image is kind of classic of what we would see in either ET or PV. We see the bone marrow be relatively full or somewhat packed with cells and much less empty space or fat. When we're looking at myelofibrosis, what we can see is this kind of black or gray stranding stuff in here is fibrosis or scar tissue that's forming throughout the bone marrow. So you can imagine based on this picture that really the soil in the bone marrow is not completely healthy in this disorder, and the blood producing cells are having to kind of form in between these strands of fibrosis, and that is why the blood counts can drop so low, because the bone marrow those cells can have trouble keeping up with the demand for cell production. So interpreting your bone marrow biopsy report. If you have a bone marrow biopsy, if you've had one before, I'm sure you've seen these reports that are anywhere from 2 to 8 pages long sometimes and have a lot of descriptions in them. So the basic things that we're looking for. So there's 2 different types of samples that we get from your bone marrow and we send down to the lab to the pathologist. The first is called an aspirate. So this is a liquid sample. So when that thin hollow needle is in the bone marrow, we can pull out with a syringe a liquid sample. From that sample, then we spread those cells in a single layer, a very thin single cell layer on a slide, so that the pathologist can look at the individual cells more closely, similar to what we do from the blood, but we can see slightly different changes in the bone marrow, or see changes earlier in the bone marrow sometimes than we can see in the blood. If the bone marrow is very packed with cells, as you could see in that prior image, those cells were really packed closely together in the ET or PV scenario, or if it has fibrosis, some scar tissue with myelofibrosis, the bone marrow may be difficult to actually pull out the liquid sample. It may be kind of socked in there or stuck in there. In that situation, that's okay. We get a core biopsy or a small solid sample that looks like that, what I had showed earlier, that 1.5 to 2 centimeter sample. We get that in either case, but sometimes we'll get a second core if we can't get the liquid sample as well. So the purpose of that is really to look at the architecture of the bone marrow and look for the fibrosis. With the liquid sample, we can't so much see the whole architecture of how things are spaced out in the bone marrow, and we can't look for the actual scar tissue. But if we can't get the aspirate, the liquid sample, then we can also get all of the same testing done from a second core sample. So important things to look for on your bone marrow report. The first thing that's usually on there is the cellularity, or the percentage of the bone marrow space that is those blood producing cells versus fat cells or empty space. So normal healthy aging process, the bone marrow starts pretty cellular when we're young, and that cellularity decreases and more fat or empty space builds up over the course of our life. So a way to estimate the expected or normal cellularity of your bone marrow is to start with about 100% and subtract your age. So if you're about 50 years old, then your bone marrow should be about 50% cellular. If you're 60 years old, bone marrow should be about 40% cellular. That's an estimate, but it's roughly about what we expect. After we see the cellularity, then we can move on to look at all those individual cells under the microscope. Erythroid cells are the red blood cells and the red blood cell precursors. Granulocytes refer to all of the different white blood cells. Megakaryocytes is just a long, complicated name for the platelet precursors, the mama platelets. And then the other cells that we're looking for in the bone marrow are lymphoid cells, plasma cells, and mast cells. So you'll see all those described there. The next important thing that we're looking at for a number is those blast cells. Remember in that prior kind of lineage diagram I showed, the blast cells are in the phase just after stem cells. They're the baby white blood cells before white blood cells become things like neutrophils, eosinophils, monocytes, those kinds of things. So blast cells are the very young white blood cells. It's normal to have some of those in the bone marrow. Between 0 to 2% of the blood cells can be blast cells in normal situations. But in things like MPNs or other related bone marrow disorders, it's possible for those cells to get stuck in the blast phase and then not mature the way they're supposed to. When that happens, it tends to they tend to build up quickly once they start to build up in that phase. And that's where we're starting to talk about something like a transformation to leukemia. If those blast cells are more than 20% of the blood or the bone marrow, that's where we draw the line and begin to call it a leukemia. Anywhere between 0 to 2% and 20%, anywhere in that lower range, we're still dealing with the MPN range. Fibrosis is the last thing we're looking at in the bone marrow report. So it requires a little bit more time. So sometimes it takes at least a few days for the pathologist to kind of stain and prepare the bone marrow sample appropriately so we can see that scar tissue. And they give it a number. Fibrosis is usually not normal to see in the bone marrow. So 0 is a normal number. And then it can go up as high as 3. So pathologists have kind of set guidelines of what they call a 0, a 1, a 2, or a 3. So that's what we're looking at initially at diagnosis, and then down the road to see if that fibrosis is building up. So you probably heard a little bit about or you may have heard a little bit about the genetics behind MPNs. I'm going to make this quick, and I'm happy to go into more detail with questions if you want it. But we know that we don't know exactly what causes MPNs for most people, but we do know that that these genetic mutations kind of set everything off in something called the JAK-STAT pathway. So most people with MPNs will have a mutation in a gene called JAK2, or perhaps mutations in genes called CALR, C-A-L-R, or MPL, M-P-L. These are all part of the same pathway. So the way I think about this JAK-STAT pathway that involves JAK2, CALR, and MPL, I think of this whole kind of apparatus as basically being a thermostat for the bone marrow. So if your body needs more blood cells, that JAK-STAT pathway tends to turn on and your bone marrow gets revved up and stimulated to make more blood cells. If you have enough blood cells, that JAK-STAT thermostat is supposed to turn down a notch, then your bone marrow is supposed to cool down. What happens when any of these mutations develop in bone marrow cells, either JAK2, CALR, or MPL, is basically that thermostat gets stuck in the on position and can't turn off. So inside the cell, the cell is getting constant signal to make more copies of itself and can't cool itself down. And mutations in JAK2, CALR, and MPL basically all affect different steps of that same thermostat pathway. So in folks with PV, the vast majority will have JAK2 mutations, which is shown here in the blue, and then a more rare form of JAK2 mutations in the red. In ET, we see those JAK2 mutations in the vast majority of people, but we can see CALR mutations in about 25%, and MPL mutations in about 5%, and some, about 10% of people with ET, won't have any of these three detectable mutations, and we call that triple negative. Primary myelofibrosis is similar to ET as far as the genetic makeup. JAK2 mutations are the most common, CALR mutations are second, and then MPL mutations are third, and triple negative are more rare. In addition, one thing that's really evolved over the course of time is the realization that it's not just these JAK-STAT mutations that are driving and contributing to these MPNs. As you can see, potentially from talking to other people with these disorders or on these meetings like this or on other support groups, you can see that lots of different people have lots of different experiences throughout their MPN course. And I think one of the reasons why these disorders are so diverse and behave so differently in different people is because of the other mutations that are involved. So we see a variety of other mutations. This list here is all other genes that can be mutated in folks with MPNs in addition to the typical JAK-STAT mutations. Some of these mutations are prognostic, which means some of them go along with MPNs that are either less likely or more likely to cause problems down the road. And some of them are not prognostic. Some of them are just there, but may change the disease behavior in one way or another. So these days, this has really been an evolving story over the last couple of years. In my own practice, my recommendation in my practice is to check for all of these different mutations at least once early on in the course of the disease diagnosis to try to help us kind of better come up with a prognosis of what we expect to happen down the road. And then potentially repeat these this genetic sequencing down the road as well if we're concerned that the disease is progressing or changing at all in the way it's behaving. So this genetic sequencing test that looks for all these different genes in one tube of blood or one tube of bone marrow is called a next generation sequencing, or NGS test. There are a lot of different labs that do this test. It's not your whole genome that they're sequencing. It's a targeted sequencing panel. So each individual lab has kind of picked out a group of genes that they think is important for these disorders, which is very similar across different labs, and they test just for those. It could be anywhere from 15 to 60 different genes that they're looking for from one test. Usually takes somewhere in the 2 to 3 week range. So if you haven't had a next generation sequencing or NGS test, I think it's worth talking to your doctor about. It could help as far as prognosis down the road, and potentially as far as, formulating different treatment options down the road as well. Another thing that we get is something called a karyotype. So this is amazing to me that when the cells from the bone marrow get down to the lab, the cytogeneticist downstairs can grow and then break up the cells and can look at the individual chromosomes under a very strong microscope with their eyes and separate them out. So we know we have these 23 pairs of chromosomes here, and they can kind of pair them up and look at them and see if there are any sections of them that are either deleted or missing or added or have crossed over with another chromosome. So this is the way a normal chromosome complement looks under the microscope, which is fun to look at. Just really quickly, I was asked to mention therapeutic phlebotomies too. I'm happy to answer more questions if there are specifics here. Therapeutic phlebotomies are used primarily for polycythemia vera, as well as a variety of other conditions out there like hemochromatosis. It's really very similar in procedure to just donating blood at the Red Cross or somewhere like that. Kind of sit in a chair, they put a pretty large gauge IV in a vein and really just remove blood cells. Sounds kind of archaic these days, that if you have too many red blood cells, that we really just remove red blood cells, but it's quick, it's easy, it's safe, and it's very effective as far as preventing blood clots and cooling down that kind of sludging of red blood cells that can happen when there are so many in the bloodstream. Oftentimes at first, when people start needing therapeutic phlebotomies for PV, we often have to do them pretty quickly because the bone marrow, as I mentioned, because of those JAK2 mutations, the bone marrow is just constantly being stimulated to make more and more red blood cells. So we remove them, bone marrow makes more. We remove them, bone marrow makes more. But over time, what happens is that the bone marrow kind of uses up its iron storage. Iron is really the fuel for this process. So as the bone marrow kind of burns through its iron storage, then we can usually slow down on the phlebotomies, and that revved up bone marrow can cool down a little bit. So that's sort of how we expect that to work. In the opposite scenario, when we're dealing with situations like myelofibrosis and low blood counts instead of high blood counts, we often have to do things like blood transfusions to fill up somebody's tanks and kind of keep them safe and keep them going. So the different blood cells that we transfuse, PRBCs or packed red blood cells, are shown on the upper here. You can see this looks very, very viscous, very thick. It's really just the red blood cells with the white blood cells and the platelets removed. So it's just red blood cells. As far as when we do this, it varies based on your health, kind of from a person by person basis. The usual threshold is if the hemoglobin drops below 7, that's when we usually start talking about doing a blood transfusion. That's different for everybody. For folks with cardiac disease or with other different medical issues, we may choose a higher number. It usually takes about 2 hours per unit per bag of blood to go in. You may get 1 or 2 bags at a time, depending on various different things with your health and the infusion schedule and the practice that you're in. The red blood cells don't last forever, and this isn't a long-term fix for anything. It's not treating the myelofibrosis or curing anything, but it is just keeping the tanks full. So those red blood cells only last on average somewhere in the 1 to 2 week range. So if somebody does start requiring blood transfusions, it's often kind of frequent and ongoing sort of thing. Platelets are shown here at the bottom. These are much lighter in color, more of a yellow color. The thresholds to transfuse platelets also varies like red blood cells, but usually it's a platelet count if it gets below 10. If you remember, the normal ranges are 150 to 400 usually, so 10 is pretty low. There's a wide kind of gray zone as far as platelet safe threshold that can be below normal but still safe. If they drop less than 10, then we worry that that's an unsafe situation as far as risk of bleeding, and we give a transfusion. Those are faster. They take about 30 minutes, but they also don't live as long. They only generally live a couple of days. White blood cells are usually not transfused because other people's white blood cells are picked up by our immune system very, very quickly. They only live for a couple of hours at the most, sometimes even minutes. So we don't usually do white blood cell transfusions, but we can use things like antibiotics preventatively to try to keep somebody safe from infections if the white blood cell count is very low. And that was more talking than I thought it was. I'm sorry about that. I definitely want to take questions though.
Okay, I have to say, just as always, it's fascinating how much more we learn when, at each of these events, and this was fantastic, very, very thorough, And we have a million questions. So let me just say this, we're never going to get to them, all of them. So for those of you listening and hoping your question is going to be asked right now, I will send these questions to Dr. Pettit and she can answer those, and we can, when we have the video prepared for this program, we will put the answers to those questions, post those with that, okay? All right, so one thing that struck me, is there any hypotheses why some patients have multiple mutations? And is there evidence that those patients do better or worse?
It's a very good question. So yeah, as far as why some people have additional mutations and some people don't, I think that's a really active area of research right now, and why these mutations start in the first place, why somebody gets a JAK2, CALR, or MPL mutation in the first place is really largely not known. And it's probably multifactorial. It's probably not well known because there's probably not one clear answer. So probably for some people, there's probably some underlying predisposition as far as your genetic makeup to start with, which is probably why these disorders can sometimes run in families, not in the same way that other things like that BRCA mutation with breast cancer runs in families. These are usually not directly inherited genes, but there can be families where the risk is a little bit higher. So it probably has something to do with underlying predisposition genetically, and then probably something to do with kind of environmental influences, who knows, food, stress, if you lived next to a refinery, anything that you're exposed to over the course of your life. Probably all goes into that as far as the initial mutations, and then probably as far as the subsequent mutations. We do know that it's more likely for people who have myelofibrosis to have more mutations than for people with ET or PV. So these additional mutations that can develop and build up over time probably promote the progression towards myelofibrosis or acute leukemia. But we can see additional mutations sometimes in ET or PV too. Some of those mutations are just age-related and things that happen, and things that may even be neutral and not necessarily positive or negative. But we do know that some of them are higher risk, or a couple of them are actually potentially lower risk. So it is important for us to check that, I think, at least at one time point. And I hope down the road we'll be able to kind of follow that serially over time for people.
Kristen, this person says, my hematologist told me that my PV diagnosis is non-complicated and that it can be managed with aspirin and hydroxyurea. Should I still get a bone marrow biopsy, or as my hematologist said, the bone marrow biopsy is not necessary?
It's a little controversial, to be honest with you. So if you look at the guidelines, we've got, so the WHO, the World Health Organization, puts out guidelines every few years that they update about our diet, that gives us, exact diagnostic criteria. And the bone marrow features is one of those major criteria, but they do have kind of a little asterisk in there. We can make the diagnosis without a bone marrow biopsy. However, it's my practice generally to do a bone marrow biopsy at diagnosis for people with ET and PV. The reason, even if we can make the diagnosis without it, the reason is that there can be some other rare disorders that can mimic ET or PV. There is some overlap syndromes with myelodysplastic syndrome, a little bit of a different bone marrow disorder that can look like ET, for example, on the blood work. There's no way to know that other than looking in the bone marrow. And also to look for any early signs of myelofibrosis right off the bat to see if there is any scar tissue starting to build up, so that we have a baseline to look back on down the road and to kind of give us a better idea of prognosis down the road. So I'm not surprised that, I know that not every hematologist does bone marrow biopsies for these disorders, and I'm not saying that's the wrong thing to do. And I know some people don't want to have them done too, understandably. But my personal preference is usually that more information is better, and I tend to do them, at least at one time point.
Yeah, most of the physicians we work with would say, I think they would agree with you on that one. All right, I'm going to try to decipher this one. If I'm on medication, I'm an ET patient, how do you confirm that if the medicine is lowering your white blood count, is that related to side effects from the medicine, or could that be progression, and how do you determine that?
That's a really good question. Yeah. So all the medications that we use to lower blood counts in folks with ET or PV can lower any of the blood counts or all of the blood counts. And it is possible it could do too good of a job with one blood cell line and not quite enough with other blood cell lines. So we can get into this kind of balancing thing where we're going up on the dose to keep the platelets down, but then the white count's dropping too low and we have to go back on the dose, and we're kind of trying to walk that tightrope. That's a tightrope that we walk every day around here in the MPN community.
Mm-hmm.
And it's hard to know. It's hard to know then over time if lowering of the blood counts is related to medication versus related to a change in the disease or progression of the disease. What I typically do, the way I manage that, is usually to back down on the medication dose and see if the blood counts rebound. And that's usually a good indication of, the health of the bone marrow overall. If we're not sure, the other way is to just repeat a bone marrow biopsy and take a look in there and see what's going on.
That's great. And how often should a patient have a bone marrow biopsy? I'm assuming at diagnosis, you tell us.
Yeah, that like everything else with MPNs, there's no one size fits all answer to that question. But I typically do them at diagnosis for everybody. I recommend them at least, unless there's a strong reason why not. And then I usually don't repeat them periodically down the road unless we have an idea that something's changing. If we're worried that something's progressing, so if the blood counts are changing one direction or the other, if symptoms are getting worse, if the spleen is starting to get larger on our examination, or if we're starting to see a change in that differential, like for example, the blast cells starting to build up in the blood, any of those things would be triggers for me to want to take another look in the bone marrow.
When should an MPN patient transfuse? I've heard to transfuse when platelets fall below 20. Some say 10, and some docs say not to transfuse unless there is a bleed.
Yeah, it depends on the individual situation. Yeah, our practice here is usually platelet count less than 10, we transfuse, but I will say here in Michigan, we have a lot of people come to us from very far away who have, trouble getting transfusions too. So that can impact our kind of goals, either wanting to keep them a little higher or let them run a little bit lower. So there's really not a one size fits all answer. My standard answer is usually less than 10, but it really depends on the person.
Okay. And what causes platelets to fall or to rise? Can stress do that? I know inflammation can. I know I experienced that with a very different issue. It was not a blood cancer.
Yeah, the platelet count in particular, but all of these blood counts can drive you crazy sometimes because there is a roller coaster. There's definitely an MPN roller coaster. Everything, the platelets are responsive to everything in your body. So yeah, I think stress hormones can cause them to rise. Certainly infections, inflammation, even just the time of day from day to day, there can be a pretty wide fluctuation in the platelet count. So with everything with MPNs, I think the most important thing to watch for over time is trends and not usually any one specific number, because it's very possible if the platelet count shoots either up or down, then the next time we check it, we could recheck it even just days or a week later, and it could be back to where it started from. So this roller coaster, as long as it's staying on kind of around an even keel and not going way up or way down, we're going to see some fluctuations based on everything else.
Okay. Does Jakafi treat symptoms or does it slow down fibrosis?
Oh, that's a really good question. So Jakafi or ruxolitinib, the JAK inhibitor, really takes that thermostat, the JAK-STAT thermostat that's stuck in the on position, and turns it down a notch. It's not specific to the abnormal cells or the cells with the mutation in them. It will turn that thermostat down and kind of cells across the board, and it does not kill those cells off. So it's not going to, I'm sorry to say, it's not going to cure these disorders. It certainly can help with the symptoms when that thermostat is turned down a notch. It can certainly help shrink down the spleen and control some of the blood counts. All those things are good things. As far as the actual prevention of progression down the road, though, is we know that Jakafi or ruxolitinib can't prevent things like progression to leukemia. We don't think it has much of a role of preventing a reaccumulation or further accumulation of the fibrosis or mopping up any fibrosis that's already there. but that's a really active area of research right now, adding other newer medications in with ruxolitinib or the JAK inhibitors to try to address some of those other things like the fibrosis.
Yes, the cocktails, yes.
The cocktails, yes.
Are there triggers or indications to make an educated guess to determine if your disease is progressing? And, you know, we all know our bodies really well and you know, understand if something's changing, but besides an educated guess, what does the physician go through in determining if I come to your office and say, you know, last week this was happening and I don't feel as well as I was the week before, and you know, what would you do?
Yeah, progression can happen in a lot of different ways in these disorders. So with ET or PV, over time, the blood counts could get either higher as the disease has been there for longer, or they could get lower as it moves along towards potentially myelofibrosis, or something like a left turn towards a leukemia can rarely, but can develop. The things to watch out for, blood counts for sure are a big thing. So any of these parameters changing, white blood cells, red blood cells, or platelets, usually dropping lower, those are triggers to think about progression. Seeing those blast cells increase in the blood is another sign to think about progression. Certainly feeling the spleen enlarge is another sign. Or symptoms to watch out for, as you said, knowing your body is really important, but I know it can be hard to tell because the MPN roller coaster is not just with blood counts. I know it can affect every aspect of your life and can be up and down on a day-to-day basis. But seeing any symptoms like fatigue, like really profound fatigue, not able to do the things that you are used to being able to do, and having that not just be one day, but kind of feeling like you're on a downhill trend energy level wise, that's the most common thing that we see when the disease starts to progress, is that fatigue or energy level or activity level getting worse and worse over time.
Okay, is it bad for one's body and or their organs to be anemic for long periods of time?
Yeah, it depends. It depends on the degree of anemia. When we're talking about low blood counts and transfusions, it's all weighing the risks versus the benefits. Your human bodies are amazing things. They can adapt amazingly to anemia, actually. If I all of a sudden had my hemoglobin drop to 7, I probably would not be able to stand up off the floor. Whereas if that happens gradually, your body and your organs do adapt to having that kind of running on half a tank. But it does, at the same time, having a hemoglobin particularly low, we think less than 7 or so, that's why 7 is our threshold. That does really start to put a bit more stress on organs like the heart, the lungs, the kidneys, those kinds of things. But we've also got to kind of balance that versus the risk of transfusions. Every time you get a blood transfusion, there's a lot of iron in those blood cells, and our bodies don't have great ways to get rid of excess iron. So that can start to build up in organs too. So we've got to kind of weigh that iron versus anemia risk over time.
Is it worth future testing to test for more acquired mutations after the initial diagnosis?
That's a really good question. I hope so in the future. I can definitely see a future where that will be the case, where we'll be doing like that genetic sequencing on a serial basis every, I don't know, 6 months or a year or a couple of years, something like that, depending on the situation. Right now, that's not very standard though, at least. And right now our trigger to repeat that is really if there's any signs that the disease is progressing into something else or just getting worse over time, that's when I'll usually repeat it. But in the meantime, until we know more about that, I'm not routinely just serially doing it unless I have a reason to, because honestly, I don't know what to do with the results right now.
Okay. What is a concerning % of immature granulocytes?
Yeah, these are such good questions.
Our patients are pretty astute.
I know, such good questions. So the immature granulocytes, what the lab is usually referring to is these cells that are in between the blast phase and the more mature phase. So not blasts and not mature neutrophils or monocytes or eosinophilia or eosinophils, but somewhere kind of in between that range. So it can be a wide range. If you have something like, let's say, an infection going on, even with a healthy bone marrow, those immature granulocytes will go up in a normal, healthy situation. So again, like anything else, it's more like it's more about the trends rather than one absolute number. I don't think there's any number I could say that is a trigger to be concerning for that. I would want to make sure those cells aren't blast cells because that's a little bit of a different situation. But in that immature range, it can vary a lot. And some people can just live long-term for many years and decades with an increased number of those immature granulocytes. So I think it just depends on the trends, really. I know that's a hedging answer.
No, that's okay. That's okay. This person has both PV and MF. What percentage of people have both?
So I guess PV and MF, my question is, so those things, I mean, those things would be related. I guess my question back to that would be, it could be that there was PV initially that then has progressed to myelofibrosis, or it could be that there's PV with just a little bit of fibrosis in the bone marrow. So that brings up actually a really interesting point, I think. Where we draw the line between these disorders is very arbitrary and changes, and I think might continue to change over time. So right now we draw that arbitrary line in the sand at whether the pathologist calls that myelofibrosis grade on a 0 to 3 scale. If it's a 2 or 3, we generally call that myelofibrosis. If it's a 0 or 1, we usually call that either ET or PV. So it's possible you could have a PV with a grade 1 fibrosis in it, or it could be PV that has moved towards myelofibrosis. And in reality, this is a wide spectrum. It's not like one thing changes all of a sudden overnight and something bounces from PV to myelofibrosis. It's kind of a spectrum. Did that answer the question? I'm sorry.
I think so. I mean, for now, yes. So we have time for a few more questions. I know it's past your time a little bit.
Okay.
Here, but I love this question. Is ET considered a cancer? And because I've been around for so many years in this space, I remember in 2008, I believe, the World Health Organization designated MPNs, including essential thrombocythemia, as a blood cancer, not a disorder. It used to be called a disorder. And I honestly, it's shocking, although physicians have the right to have differing opinions, but it's shocking to me when I get calls from new patients saying, well, he didn't or she didn't say it was a cancer. In fact, they said it wasn't a cancer. Please explain.
Yeah, it seems like that should be an easy question to answer, right? Is this cancer or not? It seems like it should be a yes or no, but it's more complicated than that. And it depends on how we define the word cancer. So if you look in a biology textbook these days, the definition of cancer is usually when one cell develops a genetic mutation and starts making more copies, more clones of itself. That's generally what's considered biologically a cancer. And that's why these MPNs were reclassified from being MPDs, myeloproliferative disorders, to myeloproliferative neoplasms back 15 years or so ago when these mutations were found, and it was realized that this all starts with one cell that then makes copies of itself. Yes. So in that way, as far as a biology 101 textbook answer, the answer would be yes, this is a cancer. However, big asterisk next to that, because we know with things like, especially with ET or PV, that these don't behave like what you think about when you think about cancers like breast cancer, lung cancer, those things. These don't form solid masses, they don't invade, they don't travel. So the effects on an individual person are much different than other cancers. That's not to minimize the effects. Obviously, there can be significant, issues with quality of life and symptoms and management over time, but these are very different and really probably fall in a class kind of on their own. I do wonder over time if these will be classified as something a little bit different than a cancer, as now there's a lot of different inflammatory disorders and things similar to like autoimmune disorders that are also found to have single gene mutations like these disorders. And I really think it's probably more fair to clump, especially things like ET and PV, into that kind of like a single gene inflammatory disorder kind of category, as opposed to a, typical cancer kind of category.
Why are iron supplements bad for MPNs?
That's a good question too. It depends on the person. It depends on the person individually. If somebody has something like PV or kind of borderline between ET and PV with a red blood cell count that's a little bit high. So, our goal with PV is to keep the hematocrit down, usually a hematocrit less than 45% for most people. although that goal can vary, and I won't get into all that for right now. 45% is the usual kind of goal to keep it below. And the purpose of those therapeutic phlebotomies, as I mentioned before, is really to deplete the iron stores over time, remove fuel from the fire from the bone marrow so that the red blood cells aren't continuing to be revved up and going. So in that situation, we want to avoid giving excess iron because we're just fueling the fire. But at the same time, we can run into a situation with long-term phlebotomies where somebody can be very iron deficient and can start to get symptoms like fatigue from the iron deficiency itself. So rarely there are situations where we'll even add back a tiny little bit of iron supplement in that situation if people are symptomatic from it. Or we'll do things like there's a new investigational drug that you might hear about called rusfertide that's being developed for PV that we're thinking of as more like a chemical phlebotomy rather than a therapeutic phlebotomy. It keeps iron in cells and keeps it away from the bone marrow. So it causes the body to be able to hang on to iron, but keeps it away from the bone marrow so the red blood cells don't see it and can't use it to make more blood cells. So at least for PV, that's the reason. For things like myelofibrosis, if people are needing chronic transfusions, we usually don't recommend iron supplements unless they're low in iron. The reason being that each bag of blood comes with so much iron already that iron overload over time can actually become an issue rather than iron deficiency.
So this is a question we get very often, but, and I'm sure you do from your patients, but that is what causes the itching and how can it be controlled?
Yeah.
Some say that the medication they take actually relieves some of the itching. Others say, you know, it's just unbearable. And itching out there yet? Because I've been hearing this for years. And so I know that some JAK inhibitors have actually helped and some other medications have actually helped with itching. But what is your recommendation?
Yeah, itching is complicated. So the itching, especially after water exposure, which we call aquagenic pruritus, which is just an unnecessarily complicated term, but this itching, it's really specific to usually polycythemia vera, but sometimes ET or myelofibrosis too, but we don't see that with a lot of other medical conditions. And the reason that it's so difficult to treat is probably because it's multifactorial. There's probably a lot of things going into that. It probably has to do with release of a lot of different substances from these myeloid cells and these red blood cells. Histamine is probably part of it, prostaglandins, other of these inflammatory cytokines. It's probably a number of different things. So any one strategy has not been shown to be kind of a one size fits all for that. Sometimes antihistamines can help a little bit. Sometimes things like SSRI medications that we think of for things like anxiety or depression, some of this can be serotonin related. So for some people that can help. The low dose aspirin can help for some people too, if it's prostaglandin related, because aspirin can reduce prostaglandins. And then the JAK inhibitors. For overall, when we're looking at just across everybody taking JAK inhibitors with itching, JAK inhibitors like ruxolitinib are pretty good to treat itching overall. But I will say I do have patients that I take care of too who have refractory itching that's not responding well enough to all of those things, including JAK inhibitors. So it's still an area where we need more management options. But trying all of those things are usually the ways that I start. We can actually the dermatologist can do some like local UV therapy to the skin that sometimes helps reduce cytokines too. That's another thing that I've pulled out of my back pocket in really tough situations. So.
Yeah, it's tough. It's a horrible side effect. Horrible. And what variable or how variable are CBCs between labs? And I love this question because I've experienced this. What causes the results to fluctuate so quickly?
Yeah, they can be definitely variable between labs and even within the same lab too. So our lab tells us that the hemoglobin the kind of error bars, the margin of error between the hemoglobin that they give us, it can be off by as much as 0.8, almost a whole point, almost a whole gram. So, and that's just a normal variation in one lab. So between labs, it can vary a little bit too. I don't think there's any one specific answer of why that is, but that's the reason why the trends are so much more important than any one number. If we see any one number that looks off or is a little lower or higher than we're expecting, it's really important to recheck it or to follow it over time and not to put too much stock in any one number.
So tell me what your feelings are with patients that you have that are on Busremi. This was the third drug that was approved by the FDA just recently, and several others are in the pipeline, but this is an injectable and it's for PV. Tell me how your patients are doing.
Yeah, Besremi. So Ropeg interferon is the newest of the interferon medications. So interferons, I will spare you the whole lecture, but they've been around for a really long time. Interferons are naturally occurring proteins in the body that kind of regulate immune responses and regulate the way that the bone marrow cells grow up and differentiate over time. And that whole kind of cascade is shifted in one direction in MPN. So giving more of these interferons can kind of shift it back, we think. And the older interferons were given injectable every couple of days, like 3 times a week, and they tended to cause a lot of kind of immune rev up symptoms, so like fevers, chills, flu-like symptoms, and it was a lot of like kind of up and down, big ups and downs every couple of days with the injections. The more recent ones are PEG interferon or Pegasus, which is injectable once a week, and it's a little longer acting, so it's a little smoother. And then this Besremi or Ropeg interferon is injectable every 2 weeks. So it's even a little bit smoother than that with less of the kind of ups and downs. So far it's approved in the US for PV, and there are trials still going on for ET right now. And yeah, I think my experience overall has been positive. I think with the interferons as a class, we're using them more and more often in MPNs these days because of some kind of early results that we've seen in terms of bone marrow health measures, looking and actually seeing the bone marrow look a little bit more healthy under the microscope, maybe seeing some reductions in the number of cells that have these mutations. Those are, we think, positive things, but what we don't know definitively yet in the long term is whether that will translate into really better long-term outcomes as far as preventing the disease from progressing or helping people live longer and better in the long term. I think that's still to be determined, and that research is still going on. But definitely the interferons are gaining popularity, I think, and are being used more and more often. We've gotten better at using them more safely and more tolerably by starting at low doses and going up really slowly. So yeah, I think Besremi or Ropeg interferon was just approved in December. So it's pretty recent, hot off the presses. Most insurance companies, in my experience so far, pretty limited experience so far, have been covering it, but we do usually have to get prior authorization and appeal and go through a number of different steps. But I have had some luck at being able to get it so far. So yeah, I think overall the experience is positive at being able to use it tolerably and having good results from it.
2 things you bring up, and one of our questions here was, what about the side effects, specifically this psychotic or psychiatric? Yeah, that's one of them. And the other thing was the insurance. So, I know this is a double question here, and I'm going back to one of the questions about bone marrow biopsies. How many will the insurance companies pay for per year? Because we do have patients that are asked to have a couple or 3 a year as as things change with them. And have you found that, number one, insurance companies are eager or okay paying for more than one? And secondly, getting back to the Besremi question, the side effects and what you're reading or seeing.
Yeah, for the most part, the side effects with any of the interferons, whether it's Pegasus or Besremi, being the 2 most common that we use, are definitely the flu-like syndrome is the number one thing that we see and that we watch for. Fevers, chills, myalgias, like achiness, fatigue, that kind of thing when we first start. COVID makes everything a little bit more tricky with that too, because I do have patients that have a little bit of that when they give themselves their injections, and they say, well, I don't know how often I'm supposed to be testing for COVID because I'm just not sure. I kind of feel a little COVID-y after I give myself the injection. So that's another consideration. But yeah, usually that typically gets better over time. Usually after the first few weeks or few months at the longest. It's usually not a long-term thing. The other side effects we watch for is any signs of like a thyroiditis, like a thyroid inflammation with excess thyroid hormone production, or liver inflammation. And those 2 things we follow from the blood counts. So if you do first start one of these interferons, we usually check the blood counts a little bit more frequently over those first few months as we're just getting started, because that's where we would see signs of those sorts of things happening, even though they're pretty rare. The psychiatric side effects that you mentioned are really important, I think. We can see people have increased levels of things like anxiety, depression, even suicidality has been reported with the interferons. I think that's quite rare, at least that extreme is quite rare. But I think a little bit of increasing anxiety is pretty common. And that's something I definitely always talk to people about, because I think it's good to have a plan for that. If you feel like you're an anxious person to start with, you're prone to anxiety or depression to start with, and you start one of these medications and aren't expecting that to get worse, and then those symptoms start to get worse, that can be obviously really troubling and really bothersome to your life. So I think knowing what to expect, have a backup plan for it, have family members and friends know that that's going on, and have us checking in on you too if you're really prone to those kinds of things, I think is really important. It does tend to get better over time. I don't think I've had anybody actually stop an interferon because of that side effect, but I will say I've kind of counseled people and kind of chosen that medication for people with that in mind, or avoided that medication for people with that in mind, for people who feel like they're very kind of revved up and have high levels of anxiety to start with. It might not be the best option for everybody. Sorry.
Go ahead.
Oh, no. I was going to skip to the insurance part unless you had.
Please do.
Oh, okay. Yeah. So insurance coverage for the interferons can be tricky, either Pegasus or Best Remy. I've had pretty good experience so far recently, at least with both of them, as far as being able to get them with appeals and a lot of paperwork needed. And there's also a manufacturer support program too. So if we can't get it through the insurance, we can sometimes get it with directly from the manufacturer too. So there's a number of different things we can try. There have been a couple situations that have come up in my practice so far where we just absolutely haven't been able to overcome the barriers, and we've had to go to a different medication at least first and save that for later. But that's sort of the exception rather than the rule so far in my experience. And then as far as kind of testing and bone marrow biopsies and those things, I really haven't had any insurance issues doing bone marrow biopsies periodically, as long as I have a reason to be doing them, which I do, because I'm not just going to do, I promise I won't just do a bone marrow biopsy for anybody just for fun. So as long as we have a reason and something we're looking for, I have yet to ever have an insurance company tell me I can't do that. But crazy things happen. I wouldn't put it past anybody to try to push back on it. And with the genetic sequencing, that we do get pushback on. Sometimes even just once. Yeah, sometimes even to just check it once, we get pushback on it. And certainly to check it multiple times down the road, we get pushback. That's getting better. Genetic testing is getting cheaper by the year, which is good. So insurance is becoming more willing to cover it. Most of the large labs that do these next generation sequencing will have programs in place too, so that if insurance companies deny it, that they'll have something in place for like a significant discount or even a free test for a one-time thing at least. So there are ways to get around it, but it can still be a little bit of a barrier sometimes.
So just to kind of wrap up, and then I'll probably send you some of these questions because there are so many. Would you recommend some lifestyle changes to MPN patients, and what would those be?
Absolutely, yes. So, I mean, changes depends on where you're starting from, I guess, but yes, absolutely. So there's been a lot of great research now that's out there and is ongoing about lifestyle changes in people with MPNs. So we know that things like an anti-inflammatory diet, which is nothing crazy. It's nothing off the wall. It's kind of a Mediterranean style diet, heart healthy diet, low in like processed sugars and processed foods, and high in like fresh vegetables and fruits and like fish and chicken and those kinds of things. That kind of anti-inflammatory diet has been shown to reduce some of these cytokines, some of these inflammatory markers in the blood, and improve symptoms, improve overall quality of life and feeling of well-being in specifically in people with MPNs and in other disorders as well. So I do think that diet is important. I think that exercise is important too. Same thing as far as improving overall health, energy levels, mental health measures, focus, brain fog, cytokine levels, all of these things. the things exercise-wise that I usually recommend to people that have been studied is like a regular cardiovascular exercise program. I'm not talking about marathon running necessarily, unless that's your thing. But really, even just like a regular walking program is great. Something that just gets the blood flowing enough to get your adrenaline up and your heart rate up a bit at least. But something that's going to be sustainable and manageable for you to continue down the road as a trend. The other thing is yoga. Regular yoga programs have been shown to decrease cytokines and improve overall feelings of health too. So if you're a yoga person, I think that's a great thing. Or if you are interested in becoming a yoga person, I think that could be a great thing as far as symptom control too.
And if you view our last recording from Washington, D.C., we brought a fitness instructor, actually a kinesiologist, who actually trains me. And I have to tell you, I was in a real slump about a year ago, and I absolutely feel like he saved my life in many ways. And so, you know, I mean, but walking, I walk every day, just about walk, you know, take a good walk every day. Also drinking a lot of water, you know, just seems to really help all of us, and especially with our brain. I just read Sanjay Gupta's book, and it was all about the brain, and water was very, very important, which we all know anyway, but thought I'd throw that in there. So Kristen, thank you so very much. You know, I know you've stayed a little longer than you had intended. We'll probably do this again soon, because we had so many people respond to this. And I'm going to send you some of these questions, and the recording, as Mallory has said, will be ready probably by Monday morning. And we will add your answers, if you have time, to some of these questions that we didn't get to today. I'll go through and make sure that they're the ones that we haven't touched. And so thank you very much. If you would like to leave our patients with one, you know, thought about the future of MPNs and what's to come, that would be great.
Yeah, I'd say, I mean, there's so much to say, but I'd say the big thing that I should end on is that there's a lot of reason for optimism right now. There is a ton of research going into MPNs over the last few years, which is really, really exciting. I say jokingly that I think that there are more clinical trials right now than patients with MPNs. And I know that's a joke, but it's true. And it's a great thing. It's a great place to be right now, that there is so much time and focus and energy and money and everything that we need going into MPNs right now to hopefully learn more about what causes these, what we can do to prevent these things, how we can better treat these things. So I think there, as Anne mentioned, there are multiple new medications that have been approved over the last year for MPNs. I think there will be many more over the next couple of years. I think we're really getting to the point of starting to chip away at these diseases a bit more, and I think we'll make a lot more progress in the coming years.
I do too. Thank you. I absolutely do. From where we were 18 years ago to today is unbelievable. And such a great group of physicians, great group of patients. I mean, the patients we've met have just been amazingly wonderful. And of course, our industry partners, we couldn't do any of this without them. And you would not have medications without them. So we thank them as well. And we will talk with you real soon. We'll send you these questions. And thanks again for your time today. Really.
Thank you. I really appreciate it.
It was great, Kristen. Thank you.
Thanks.